Good afternoon. I am Dr. Brindha. I will be presenting my paper on evaluation of dry eye in rheumatoid arthritis and systemic lupus erythematosus and its association with anti-SSA and SSB autoantibodies. As we all know, dry eye is a multifactorial disease and the ocular surface is maintained by a tight immune regulation. In autoimmune diseases, this immune regulation is breached, and autoimmune disease has two types of dry eye, which could be primary Sjogren or secondary Sjogren. In primary Sjogren, it's associated with anti-SSA and SSB autoantibodies. In secondary Sjogrens, we suspect self-reactive immune T cells, which causes lymphocytic infiltration in the lacrimal glands, which impairs the tear production and results in dry eye. The aim of our study was to estimate the prevalence of dry eye disease in rheumatoid arthritis and SLE patients and to identify the association of dry eye disease with anti-SSA-SSB autoantibodies. The study group included patients above 18 years of age with rheumatoid arthritis according to ACR-Euler 2010 criteria or SLE according to ACR-SLIC 2012 criteria, and we recruited 90 RA patients and 55 SLE patients. The exclusion criteria were active keratitis and conjunctivitis, cicatrizing ocular surface conditions, and lacrimal gland malignancies and sarcoidosis. Methodology was, we noted the duration of the disease, and disease activity was calculated based on the DAS28 or SLEDA index. Dry eye symptoms were noted, and the patients were subjected to two structured questionnaire, OSDI questionnaire and speed questionnaire. Topical and systemic medications were noted, anterior and posterior segment examination was done, and the patient was subjected to Schimmer's test, ocular surface staining, done with two scoring systems, SICA OSS scoring and National Eye Institute scoring, and tear film breakup time was noted. Serology was done to look for anti-SSA-SSB autoantibodies. Coming to the results, in RA group, the mean age of the population was 44 years, and in the SLE group, it was 32 years. And in both the groups, majority of the population were females, and the median duration of the disease was 6 years in rheumatoid arthritis and 7 years in SLE. The disease activity in both groups, the majority of the population were in remission or low disease activity in RA and no flare with SLE. Symptomatic dry eye disease in rheumatoid arthritis was 32 patients had self-reported dry eye symptoms, and on structured questionnaire, speed questionnaire was able to assess more dry eye patients when compared to OSDI. This discrepancy was because some questions in the OSDI were not applicable to the Indian setting. The similar pattern was noted in the SLE group also. 14 patients had self-reported symptoms and 29% of patients had dry eye based on speed questionnaire. Dry eye disease prevalence in RA and SLE group, the majority of the population in both groups had abnormal tear film breakup time and ocular surface staining when compared to OSDI or speed scores and Schimmer's test. Tear film quality was affected more than the quantity, and this suggests the subclinical dry eye disease was more prevalent than the symptomatic dry eye disease. Despite the symptoms in both groups, which was 35% in RA and 25% in SLE, less than 5% were diagnosed with dry eye and were on treatment. This highlights the need for vigilant screening for dry eye, irrespective of symptoms, disease duration, and disease activity. Relating to dry eye disease to the disease duration and activity, in both RA and SLE group, there were no significant association. Still, the patient had abnormal TBUT and ocular surface staining scores. This suggests a subclinical dry eye disease with minimal disease activity. Majority of the patients had meibomian gland dysfunction. This was explained because of immune complex deposition in the meibomian gland and like methotrexate usage in rheumatoid arthritis patients, which aggravated the blepharitis. So lid examination is as important as the tear film assessment in case of dry eye disease. Anti-SSA-SSB autoantibodies were detected low in rheumatoid arthritis patients, and anti-SSA was 31% positive in SLE group. Still, the dual antibody negative patients had abnormal TBUT and ocular surface staining scores. Coming to the discussion, in our study we have found abnormal ocular surface staining and TBUT scores were more than the abnormal Schimmer scores. Ocular surface inflammation was more than decreased tear production, no significant association with SSA-SSB autoantibodies. Anatomical target was ocular surface epithelium than the lacrimal gland, which is because of increased pro-inflammatory cytokines on the ocular surface. Secondary Sjogren syndrome pathway could be a minor mechanism causing dry eye. Postulated dry eye pathway, it's because of multiple risk factors causing autoreactive T cells, abnormal neutrophils, or activated corneal Langerhans cells resulting in the ocular surface inflammation. And the strength of a study was, it is the first study to report dry eye disease in both the SLE and RA groups, and the first study to utilize two subjective dry eye questionnaires, OSDA and speed, demonstrating a speed has greater applicability in our setting. Limitation was, we did not assess for the tear film hyperosmolarity, and majority of the patients were in like remission or low disease activity. We did not, severe disease activity was not noted, so the correlation with the dry eye disease cannot be commented. Conclusion was, dry eye disease is not associated with SSA-SSB autoantibodies, disease duration and disease activity. Subclinical dry eye is more prevalent in SLE and RA groups. Vigilant screening is advised, and dry eye symptom assessment should be done, followed by tear film quality, quantity, and lid examination is very important in dry eye disease patients. These are my references. Thank you. Thank you, sir.
Have you done any inflammatory markers for any of these in the tear film?
No, sir. Not
So your study is only based on the antibodies and their correlation to the disease.
Yes,
and
sir.
you were saying that
It's
they have
not,
no
association.
correlation. It can always be there in
Yeah.
spite of the antibodies being present.
Negativity.
Okay, thank you.
Thank you, sir.